remarks, and we will now recognize Ms. Hayes from Connecticut for 5 minutes.
Millions of Americans across the country are hit with unexpectedly high medical bills because of increased hospital consolidation. Studies show that consolidation has consistently produced higher prices for care. According to the American Hospital Association, between 1998 and the end of 2021, there were 1,887 hospital mergers, reducing the number of hospitals from 8,000 to just over 6,000. This consolidation includes hospitals acquiring independent physicians' office and converting them to hospital outpatient departments. Under the current system, these departments can fully charge facility fees and receive higher reimbursements than freestanding physicians' offices to other lower cost settings. There is little evidence that the quality of care is higher, and that in many cases, physicians' practices were brought by hospitals and designated part of the outpatient department just to take advantage of this rule. Ms. Monahan, you discuss hospital billing practices that make it difficult to determine which setting is providing the service. This includes when a service is provided in what is effectively a doctor's office, but is billed at the hospital rate. While the plan has no way of distinguishing the setting in which the care took place, can you tell us a little bit about, if you don't know the location of where care is provided, how is a plan supposed to determine the rate of payment? And would providing accurate information on the site of service improve transparency?
Absolutely, providing this would improve transparency, and the payers, as well as state officials, state regulators, federal regulators looking at this, really just cannot see the actual location where care took place, and they can't make their decisions to say, this is an off-campus, this is a physician's office that's miles off campus, it looks like a hospital to us, and figuring out what to pay then becomes much more difficult. Or if you want to adjust, this is a lower quality practice that a hospital now has acquired, maybe we don't want to contract them or we don't want to pay them as much. If we can't see that is where the care is being provided, rather than it all just looks like it's on the main hospital campus, it makes it a huge challenge to implement reforms.
Can you just help us understand a little why it would make a difference? I think to Mr. Scott's question, if a service is being provided, does the setting, should the setting determine the rate of reimbursement for that service, whether it be an MRI, an ultrasound, whatever?
Ideally, no. I think that's the system we want to move to, where for care that can be safely and effectively provided in a physician office, we should not be paying more when it is being provided in a hospital-owned setting. Right now, what you see states trying to do, like Indiana, is to say, at least off-campus physicians or physicians' offices, let's not pay facility fees there. And so, but payers may have difficulty implementing that if they can't see where the care was provided.
Thank you. Ms. Tripoli, in your testimony, you discussed the lack of transparency concerning the business practices of PBMs, or pharmacy benefit managers. As you know, in 2022, 80% of all equivalent prescription claims were processed by 3 companies: CVS Health, Express Scripts through Cigna, and Optum Rx through United Healthcare Group. What are some of the problems that may arise because of how PBMs are currently compensated, and how would transparency help in these issues?
Thank you very much for the question. I think the first thing to say is the reason we have a drug affordability crisis is because of price gouging from drug companies. But it is also important to note that PBMs, of course, have a role to play. There's just an incredible amount of opaqueness around the PBM business practices and contracting practices. They are, to your point, 3 major PBMs owning 80% of the market. Giving them this market power gives them increased negotiating leverage with the drug companies to get price concessions. But the result are pricing structures that are not always in the interest, the financial interests and health interests of the American people. And so increased transparency, pulling back the curtain, understanding what's happening around the rebates, the actual negotiated rates, is going to empower employers to actually be able to negotiate to get a better deal for their employees.
Thank you. That was one of the things that Democrats tried to do, was Medicare negotiating the price of prescription drugs, increasing competition in many of these workplaces. How does the lack of competition impact an ability to better deal with PBMs? In 15 seconds.
The main thing that I haven't said is that PBMs can actually steer patients to their own pharmacies, taking away choice from consumers. which is hugely problematic for their access to pharmaceuticals.
Pretty basic. Thank you. That's all I have. I yield back.